Bismillah ar-Rahman ar-Rahim. Now we will discuss the third part of pediatric emergency. We will talk about asthma. Asthma is the most common chronic illness in children worldwide. It is a major cause of chronic morbidity and mortality throughout the world. It is a chronic reversible inflammatory condition of the lung airways resulting in episodic airflow obstruction. This chronic inflammation heightens the twitchiness of the airway, what we call airways hyperresponsiveness to provocative exposure. Now, how we can manage a case of acute attack of asthma or asthmatic exacerbation? Mild attack can be treated at home. Indications of hospital admissions include moderate to severe attack which does not improve within 1 to 2 hours of initial treatment, prolonged symptoms before admission, inadequate access to the medical care and medications, difficult psychological conditions, and difficulty in obtaining transportation to the hospital in event of further deterioration. Home management include immediate inhaled short-acting beta agonist by nebulizer, ventral nebulizer, up to 3 times per 1 hour. Good response is characterized by resolution of symptoms in 1 hour, no further symptoms over the next 4 hours, and improvement of peak expiratory flow of 80% predicted or personal best. If the child has incomplete response to beta agonists, that is, persistent symptoms and or PF of 60 to 80% or predicted or personal best, so we can use short course of oral glucocorticoids, for example, prednisolone 1 to 2 mg per kg per day for 4 days. The most important thing here is the hospital management of acute exacerbation of asthma. These steps include auto-administration, close monitoring of the clinical status, inhaled short-acting beta agonist every 20 minutes for 1 hour, that is Ventolin or salbutamol nebulizer. If necessary, systemic glucocorticoid, prednisolone 2 mg per kg per day, oral or IV, or sometimes we can use hydrocortisone or dexamethasone. In very severe attack, we can use methylprednisolone at 1 mg per kg per dose every 6 hours for 2 days, then decrease dose to 1 to 2 mg per kg per day in 2 divided doses until PF, that is peak expiratory flow, reach 70% of predicted or personal best. Inhaled ipratropium bromide is anticholinergic, may be added to beta agonists if no significant response is seen within first inhaled beta agonist. Subcutaneous epinephrine may be given in severe cases with serious, sometimes severe side effects like severe tachycardia. Eye fluid may be given in persistent severe dyspnea, slightly below maintenance due to increased ADH or antidiuretic hormone. In status asthmaticus, the following option may be added to the previous treatment. This include intubation and mechanical ventilation, IV beta agonist, IV theophylline, inhaled heliox, that is helium and oxygen, IV magnesium sulfate as smooth muscle relaxant. Patient may be discharged home if sustained improvement in symptoms, normal physical findings, PEF more than 70% or predicted or personal best, O2 saturation more than 92% on room air for 4 hours. Discharge therapy include inhaled beta agonist up to every 3 to 4 hours plus glucocorticoids 3 to 7 days course of prednisolone. We'll talk also about Stridor as an pediatric emergency. Stridor is a continuous inspiratory harsh sound produced by partial obstruction in the region of the larynx or trachea. Total obstruction can lead to cyanosis and death. What about etiology of stridor? Infectious croup is the most common cause of acute stridor, as acute viral laryngitis, spasmodic laryngitis, laryngotracheal bronchitis, acute bacterial tracheitis, acute bacterial epiglottitis. Hospital management of cases of stridor indicated in first, in any infant with stridor at rest. Second, any child with stridor with retraction. Third, suspected bacterial disease, for example, in high fever and severe obstruction. Fourth, stridor with cyanosis is an indication of immediate hospitalization and endotracheal tube intubation. The mainstay of treatment for children with croup is airway management and treatment of hypoxia. Treatment of the respiratory distress should take priority over any testing. Most children with either acute spasmodic croup or infectious croup can be managed safely at home. Despite the observation that cold night air is beneficial, a Cochrane review has found no evidence supporting the use of cool mist in the emergency department for the treatment of croup. Nevertheless, this type of treatment is commonly used. Children with both wheezing and croup can experience worsening of their bronchospasm with cool mist. Close observation, frequent monitoring of heart rate, respiratory rate, degree of retractions, color, and level of consciousness is very essential to assess the course of the illness and to identify those in need for endotracheal intubation. Minimal disturbances is important. Nursing and medical procedures which disturb the child or increase anxiety should be minimized. The mother should remain beside the child for reassurance, at least until he sleeps. Drug therapy, it includes corticosteroid. It is the most commonly used and the most essential therapy in croup. Decrease edema in the laryngeal mucosa through their anti-inflammatory action. A single IM dose of dexamethasone, 0.6 mg per kg, sometimes a dose as low as 0.15 mg per kg may be effective. Oral dexamethasone is also effective. Oral prednisolone, 1 to 2 mg per kg may be used. The second type of therapy can be nebulized epinephrine. This may lead to marked decrease in the need for tracheotomy in croup. The mechanism of action may be the constriction of the precapillary arterioles through the alpha-adrenergic receptors. This leads to fluid resorption from the interstitial space and a decrease in the laryngeal mucosal edema. Nebulized epinephrine is indicated in moderate to severe stridor at rest. Second, the need for intubation. Third, respiratory distress. Fourth, hypoxia. It should be used cautiously in patients with tachycardia, heart condition as tough, and ventricular outlet obstruction because of the possible side effects. The third modality of treatment is antibiotics. They are not indicated in croup because, as you know, the most common cause is viral, especially parainfluenza virus. But it is important when a bacterial infection is suspected, especially in those with high fever. The choice are ceftriaxone, 50 mg per kg per day, single dose, or 100 mg per kg per day in 2 divided doses, or a combination of ampicillin plus sulbactam. Sedatives are contraindicated because they impair consciousness. A helium-oxygen mixture, Heliox, may be effective in children with severe croup for whom intubation is being considered. Oxygen therapy is important. It relieves hypoxia. It has 2 disadvantages. It delays the appearance of cyanosis, which is an important indication for mechanical ventilation, usually rejected by a child and makes him worse upset. Feeding by maintenance eye fluid is usually needed during the first 24 hours. Careful oral intake is initiated from the second day. Mechanical relief of obstruction, 98% of cases improve within 48 hours within the previous measure. In 2% of cases, endotracheal intubation or tracheostomy is indicated. The main indications are cyanosis, altered consciousness, extreme restlessness, or gradual progression of the degree of the airway obstruction. Patient may be safely discharged home after 2 to 3 hours period of observation, provided there are no stridor at rest, normal air entry, normal color, normal level of consciousness, and giving steroid. Thank you very much.